For those new to Mpowder, we are a co-invention community focused on just one thing, helping women to be well by making sense of what actually helps, alongside our award-winning formulations created with and for the women we serve, just like you. One of the most important things we do is facilitate access to the best experts in their field. So you're not left trying to interpret headlines, trends, or algorithms on your own. And February's masterclass is no exception to that principle. Michelle Gordon is an obesity medicine physician specializing in metabolic adaptation and long-term chronic disease strategies for midlife women like us. She has practiced medicine since 2000 and brings more than 2 decades of clinical experience to her work in metabolic health. Board certified in obesity medicine and lifestyle medicine too, Dr. Gordon focuses on the predictable biological patterns that drive weight gain and regain in high performance women during midlife. And her work centers on things like insulin resistance, shifts in body composition, fat mass defense, all across that menopause transition we go through. She's also a fellow of the American College of Surgeons and the American College of Osteopathic Surgeons. Her surgical background actually informs, I think, the way that she approaches this whole conversation. It's very structured, it's system-based, and it really is focused on what is effectively chronic disease management. She's known for translating complex metabolic physiology into clear, clinically grounded strategies for women seeking long-term medical leadership in obesity care. So if following this masterclass you would like to work with Dr. Gordon, you can actually gain early access now to the predictable patterns behind midlife weight gain, which is a sort of physiology-based self-paced training program that she's developed on metabolic adaptation, fat mass defense, and weight regain. You can find that at www.drmichellegordon.com. And if you're in the USA, you can also head to the same URL to apply to work with her privately on a one-to-one basis too. Following this introduction, there's a short reflection from me on what to expect and an invitation to share. I also want to highlight, although it will also appear, there is a legal statement on screen. We're here to explore ideas and evidence together, but this conversation is not a substitute for personalised medical care. Always please check with your healthcare provider before starting, stopping, or changing anything. Thank you. If midlife has left you feeling like your body has betrayed you, weight gain, craving, sleep disruption, mood shifts, stubborn belly fat, this masterclass helps us understand what's actually happening and why it's not a willpower problem. Dr. Gordon brings both lived experience and medical expertise to the conversation, explaining how female biology changes across puberty, pregnancy, postpartum, perimenopause, menopause, and surgical menopause too, and why we as women are not small men. We talk about how shifting estrogen, progesterone, testosterone, and sex hormone binding hormones affect our feelings of fullness, satisfaction when we eat, our fat distribution, insulin resistance, and even food preferences. The session also breaks down the real appetite regulation network, so Ghrelin, leptin resistance, GLP-1, and other gut hormones, and why things like sleep disruption can intensify our carbohydrate cravings. There's so much to learn here. It tackles common diet and weight loss myths head on, reframing obesity as a chronic, relapsing, regulated disease rather than a character flaw. Dr. Gordon explains how GLP-1 medications work and what the side effects are, why so many people regain weight when they stop, placing the conversation in the context of a long-term disease that we need to manage. You'll also hear some practical, clinically grounded guidance from her perspective on maintenance. Now, this is a woman who's got a lot of experience working with women one-on-one. She talks about monitoring patterns over time, and she also talks about the discussion of connecting biology with real life, stress, caregiving load, the broader gaps in women's health research, so we can all navigate midlife with clearer expectations and more agency. This is a science-forward, balanced conversation designed to replace some of the confusion and shame with a framework we can actually use, but it doesn't have all the answers. And I think that's really important to flag here too. Science doesn't stand still, and neither should we. Our job in supporting you as a community is that we stay curious. We keep asking the questions. We keep pushing for proof. And with that in mind, if you've any questions following tonight's digital premiere drop, please do email us. We're at healthconcierge@mpowder.store. I'll also put it down in the show notes if you're catching up on YouTube. But please, I feel like this is a conversation that we're going to continue, and I'd love your perspective on how we shape it. Enjoy the show. Dr. Gordon, such a privilege to be able to pick your brains on the topic of midlife today. And as you know, I've done quite a lot of research to find the voices that our community really turn to, and your name just kept coming up. So thank you first and foremost for bringing your brains into the Mpowder community.
Well, thanks for having me.
It's absolutely a pleasure. So I'm very excited about everything that we're going to be talking about. But before we get started, I know that when you and I had a pre-call, you spoke to me a little bit about how you got into this area. And I think actually as a researcher, for me, it was really interesting based on when that happened in your life, how you focused your lens on female health and metabolic health. Can you just talk to me a little bit about how you came to focus on it, and I guess what led you to what you're doing now?
I trained as a surgeon. I was a general surgeon for 20 years. And right around midlife, when I noticed that I was just laying on the couch reading a book and all of a sudden felt embarrassed, I had no idea what was happening. It was interesting because I felt like my body had betrayed me. I gained a bunch of weight. I didn't understand what was going on. I was crying at commercials. And and I had two frozen shoulders, which at the time we didn't even know was a sign of
Yeah.
menopause. And I needed to find a solution. I tried hormones, I kept bleeding. I was like, this is not going to work for me. And so I found a protocol that worked for me that was based on exercise and diet, but I never really lost my weight. And
Mm.
I had a baby when I was 29 years old, and I gained weight with that baby and I never lost it. I'd lose a little bit, then I'd come, would come back, and I'd lose and come back. And then, when I first started my practice, I was very focused on that and I gained a whole bunch of weight. And as I started moving more, I was able to get to a certain point, but I could never get below it. Or if I did get below it, it was so restrictive, I couldn't stay there.
Mm.
And I wasn't able to keep it up. And all this time I was exercising 4, 5, 6 times a week and training for triathlons and doing a lot of exercise. And when I was really busy as a surgeon, I had 4 surgeons working for me. And then at the end of 2019, one of my surgeons, the one who was my medical director, he died by
Mm.
suicide.
Oh gosh.
And that kind of made it was like a big light bulb moment. I was like, do I want this? And it had to do with his personal life. It didn't have anything to do with his work, but I was already very unfulfilled in the work. I was tired of not sleeping through the night. And I had been 20 years of not sleeping
Yeah.
through the night. And I realized I needed a change. COVID came and I just closed it all down. I was like, I need to do something else. And I completely
Wow.
rejected medicine, thought I was going to leave medicine altogether. And then about 3 years into my sabbatical, I realized that I have this skill set. I have a medical
Mm.
degree, what I spent my life studying, but I don't necessarily have to do surgery to do it and to be fulfilled. And that led me down the path of getting board certified in obesity medicine, getting boarded in lifestyle medicine, and learning a lot about women's health. And
Mm.
that's what led me here. I had already studied a bunch about menopause, and at the time, women's hormone replacement was still pretty demonized
Yeah.
because of the Women's Health Initiative, where
Mm.
the lead researcher went to the press instead of going through the proper peer review channels. And overnight, about 40% of women who were menopausal were on hormones, and it went down to 0.4%.
Yeah. Yeah. It's crazy.
And the funny thing is, when you dig into that study, there's a great book called Estrogen Matters that
Yes.
I recommend everybody read that really goes into the flaws of that study. But when you dig into it, patient selection was poor. Most of the patients were already postmenopausal. And the type of progesterone they used was a synthetic progestin. They
Mm.
also used a bad estrogen. They used a Premarin, which comes from a horse. But when you look at the data, there wasn't really appreciable breast cancer risk when you control for age. And the synthetic progestin was also not bioidentical.
Mm.
So when you look at that, we see that bioidentical hormones do not cause breast cancer. They do not appreciably increase women's risk of blood clots. And when you look at all that data, and it's what the functional medicine doctors, the longevity doctors, saying that all along. Longevity medicine is really more about having a good long quality of life.
Yes. Yeah. Health span. Yeah.
Yeah. So that's my story, and it's really a story of reinvention because
Yeah.
I had to become somebody different. And so I just went into, well, where are my skills and what do I like and how can I make good? And so it really does help in midlife when we are no longer have the responsibilities that are foisted upon us, and we're able to take a step back and look at, well, what do I like and what do I want to do and who do I want to be? And I was able to discover things that really turned me on when I was a kid, but I'd put aside things like gardening and
Yeah.
baking and writing, just things that I had focused on when I was younger, when I didn't have any big responsibilities, and I came back to them. And so now I have this little homestead where I've turned as much of my land as I can into space that will grow food.
Yeah. That's
And
amazing.
I bake
And I mean, it's,
sourdough.
yeah, yes. Oh, we need to talk about sourdough. It's amazing listening to you speak because, from a research perspective, we know that as we navigate midlife, alongside the swirliness of what's happening biochemically and perhaps in part as a result of that, many of us turn to a greater sense of purpose and start thinking about how we want part two to be and what drives us. And as you say, those passions that have maybe been dormant because of the expectations placed upon us or just because life got too busy, if you give them time, they bubble up. But I think the really fascinating thing about what you've done and what you're doing for females everywhere is that sense of looking outward can only really happen when you're well. And the world isn't very good helping us to be well. And I think that what I found really exciting about the way that you work is that one, it was born out in part from personal experience, right? Which I always think is fascinating about the way that women just go, okay, so I'll just go and sort it out then. No one else is going to. And so many women in this space have come through a personal lived experience, whether that is losing the love for something or just finding their body, like you say, and that comment of my body had betrayed me, I hear so often in our
Yeah.
community. And it's a really frightening thing as well, because you don't know what's going on. You're medically trained and you didn't necessarily join the dots. And I know we're learning more and more about the symptoms associated with this life stage, but there are so many because obviously these hormones impact every single cell in our body. So I think it's amazing that we're getting these voices. And what I love about your voice is I think there's a lot of similarities, interesting, in the way that hormone therapy was depicted, and then the sort of the binary debate that started in the UK that is playing out now in the US and becoming more balanced. But this sense of something being totally demonized, and also females' bodies and the decisions we made being a sort of a group choice, the
Mm.
societal choice. And then similarly, we're seeing the same, I think, to a certain extent. We're going to come on to talk about weight loss medication in a bit more detail, but there as well, it's become like this kind of political debate around morals and principles and whether being on a medication means you're not trying hard enough, which is how hormone therapy was depicted at one point, wasn't it? It was like, well, I didn't need it. I just pushed on through. And it was almost a sign of weakness to be on it. And then it was a sign of weakness to not be on it. And then you ended up with a balance where there was this recognition that hopefully women do have permission to take agency for their health. And it's really no one's business but our own. And then the holistic piece that has to sit around whatever intervention we walk through, because we don't necessarily have the answers at the moment, and also each body is beautifully different. And I think that's again what you bring to the work that you do. So I'm really excited about having the conversation, and I think doing it in this setting ensures that the people that are then going to receive this as a recording, they've got the weight of your thinking. So I know you've provided a slide deck to keep us on track. I really appreciate that, because I think that is the challenge as we start exploring this modality, is being able to be honest about what we know and what we get to learn. And that's the beauty of science, but quite often it's painted in black and white, and that makes it really hard as well in terms of expectation management and knowing how to navigate stuff. And I feel that, again, a bit like HRT, when things become too binary, it doesn't really help the women that we're looking to serve, because they're just left following different feeds and getting completely different perspectives on what's
Yeah.
helpful. And if they don't find the answers, they end up sub-optimizing on Substack or Reddit, where going down these wormholes because you're not getting the clarity that you hope for. So without further ado, I would love you to pull up your slide deck, and we're going to have obviously a conversation, but thank you in advance for the fact that you've made it so clear and concise in your slides. Let's zoom out before we start this conversation with the deep dive we're going to go into. I would love you to begin by talking a little bit about the beauty and complexity of female biology, and specifically the impact our female metabolism has across our lifespan as women.
Well, I think the first thing we have to say is that women are not small men. We have a different hormonal profile, we have a different biological profile, but at puberty, we have the changing that happens, and we get warned about that, right? We have
Mm,
sex ed or whatever, and our parents tell us that bodies are going to change, and so we expect it.
mm,
And then again, in pregnancy, we can have some things change with our weight. We've never really studied pregnancy and its effect on metabolism, especially the obesity related metabolism of women, specifically if you're metabolically healthy when you get pregnant, but you come
mm,
out of it and you can't lose the weight. There are some new longitudinal studies that are in process now, but it's just really baffles me that we have one gender that births the entire species that is just so understudied. So then in postpartum, if you've gained weight, for the most part, for most women, not all women, but for most women, then you have a new set point and that's defended.
mm.
And then in perimenopause, you have accelerated fat gain. And because of loss of estrogen and progesterone and testosterone, you can lose your lean mass. And then if you have surgical menopause, then the obesity risk increases. So let's talk a little bit about the hormones that are involved.
Yeah.
So midlife weight gain, we've got two things working together. We've got aging and declining estrogen. And both of these increase the total fat mass. They shift where fat gets stored. So from peripheral, so out, my arms, hips, legs, it goes to central.
It'd be really good to understand a little bit more about the impact of our sex hormones on weight change in midlife and that kind of whole body impact. If you can talk to us a little bit about those, that would be really interesting to understand
Yeah,
better too.
so estrogen does three things that will protect against central fat. Okay. It increases satiety through what's called the melanocortin and cholecystokinin signaling pathway. And
Wow.
this directs fat to subcutaneous storage instead of visceral. So outside instead of
Mm,
inside, right? And this also increases what's called thermogenic activity, which is more calorie burning. But when
right.
estrogen declines, you're going to lose those protections. So fat moves to the abdomen. It moves to the subcutaneous tissue of the abdomen plus inside.
Mm,
And then beyond estrogen, we have progesterone and testosterone,
yeah.
these, and also sex hormone binding globulin. Okay. And these all decrease with menopause. So lower sex hormone binding globulin means you have higher bioavailable testosterone. And this is strongly associated with insulin resistance.
Mm,
If you have high, if you, so as far as free testosterone goes, total testosterone, it may stay stable or it may decline depending on how a woman manages in menopause.
right.
But again, bioavailable testosterone goes up as sex hormone binding globulin drops. And this predicts visceral fat accumulation and also the mustache on your face.
Oh,
More testosterone leads to more hair. So when you start complaining of
yes.
chin hairs and mustache,
Yeah,
and then also like when you replace testosterone, you're going to get some hair there. And I've decided
right.
that it's worth it. I just shave. Um, and then you have the biochemistry of how this all works. We have a signal coming from our brain, the follicle
Mm,
stimulating hormone, and it comes out. And what it does is the brain sends out these hormones and pulses. And when
right.
these hormones come out in pulses, the ovaries respond by giving us our sex hormones. When this pulsation stops, the whole system shuts down. And
Wow.
so, what happens in menopause is the brain says to the ovaries, hey, where are my hormones? Where are my hormones? And it starts putting out more and more follicle stimulating hormone, but the ovaries have failed and they can't respond. And so that's
Hmm.
why the lab results, now again, we could talk about normal labs and how they don't mean anything, but
Mm,
lab results of menopause are that you have high sex hormone binding globulin, low, usually low progesterone and estrogen, and then we have
mhm.
variable testosterone. So the other thing that happens is that this follicle stimulating hormone increases, but we have follicle stimulating hormones in our visceral fat. And that's
Right.
why we have more visceral fat during menopause or the middle belly or the middle spread.
Yes.
But then we kind of have to
That's
talk about insulin. So we still have to talk about
yes.
insulin. So insulin resistance will develop parallel to the hormonal changes. And when this happens, then you can have more body composition changes. So
Mm,
what matters clinically is that weight gain drives hormonal changes more than hormones drive weight gain.
That's so interesting because that's not something that I had
Yeah.
heard before. Can you break that down a little bit for me? Yeah.
If I measure your
Mm.
waist circumference today,
Hmm.
I can predict what your sex hormone binding globulin, testosterone, and FSH will look like in the future.
Wow.
Okay. But if I measure those hormones today, I can't predict your future waist circumference very well.
Right.
Okay.
Right. That's really
Um,
interesting.
yeah. Estradiol is different. It works both ways. So low estradiol increases central fat accumulation, and central fat accumulation lowers estradiol. So it's a confusing kind of picture,
Mm.
and they don't teach it in medical school.
Wow.
I got
That's
no
phenomenal.
training on women's health in medical school.
Yeah.
Even when
Which
I
is,
did my OBGYN rotations, we didn't talk about menopause.
it's
Um,
phenomenal. I remember seeing a
yeah.
stat that said something like 80% of the OBGYN postdoctorates don't cover menopause, which is
Mm-mm.
just crazy.
So this is what we just talked about. So
Mm,
the waist circumference will tell us what your sex hormone binding globulin, testosterone, and FSH levels will look like. It's
crazy. I
really
hadn't
interesting.
heard that before. I hadn't
Yeah.
heard about that as a way of doing things. That's phenomenal.
So
Um,
the whole body impact of that
mm,
is that in the cardiovascular system, central obesity increases the risk of sugar management problems. All
mm,
right. So we call it dysglycemia, for lack of a better term. So prediabetes, dyslipidemia, hypertension, cardiovascular disease. So this is all inflammation. So in obesity, visceral fat specifically acts as an endocrine organ.
right.
And that's why it is so defended, because it just wants to keep itself there. Estrogen receptors will regulate glucose and lipid metabolism all throughout the body. The lean body mass decreases in the musculoskeletal system, especially in the lower limbs. And then also, so if you're in menopause and you're always forgetting things,
Mm,
right? Estrogen has a big effect on the neurological system, and it influences dopamine pathways. And it actually really not just about brain fog and sleep and all these things, but it also changes your food preferences. So
wow.
prefrontal cognitive controls of eating. Now, menopausal hormone therapy will favorably influence fat distribution, but you can't recommend menopausal hormone therapy as an obesity treatment. So it's not a weight
Right.
loss treatment. It
Yeah.
is a overall like health treatment.
Right. Okay.
So
That's so interesting. So many people in our community, and I know we're going to come talk about this in a bit more detail, but they talk about the weight gain piece, but also, as you say, what we crave, what we find ourselves wanting and obsessing about in terms of food groups or food types that change dramatically during this transition. Again, just frustrate us. And back to the sort of beginning of our conversation, that sense of betrayal where you don't want to be grabbing the sugary pastry mid-afternoon, but that's all you can think about, and it's the only fuel that your body seems to respond to, even if it's just incredibly temporary. So it's really
yeah,
interesting to hear. Again, I hadn't heard that that actually is impacted by the menopause journey. That's phenomenal.
well, it's really interesting because I have survey data from over 20,000 women. And some of the things that really popped out to me when I was analyzing this was some of the quotes were like, why do I think about food all the time? Why do I crave
Mm,
food? Why won't the weight shift? All these things that happen, and it's hormonally mediated. So we can't forget about this. There is one study that I want to mention. It's the study of
mm,
women's health across the nation, and it found that there were associations between hormone therapy timing and obesity risk. But again, observational findings. I'm
right.
not really sure whether there's any causation there. But it's
Mm,
very important that we look at surgical menopause as an increase for severe obesity risk. So
mm,
before you go in and have that hysterectomy, really talk to the doctor. There are reasons why you would do it because of cancer, for
yeah.
example, breast cancer, ovarian cancer, BRCA genes. It's really important that you educate yourself. It's very important.
Mm,
And when
mm,
you remove your ovaries, you're going to have something called genitourinary syndrome. So when you remove the hormones, this happens in menopause, the vagina actually atrophies. So it's really important to get hormones to the vaginal tissues.
mm. I think the whole piece around surgical menopause is woefully under supported in the systems that we tend to go through. And a lot of work is happening at a charitable level here in the UK where, again, often individuals who've had a very painful lived experience will look to try and Yeah, agitate for change, but it's not talked about enough. And many people go into surgical menopause with no idea as to what to expect when they come out the other end, and very little support for them as well. So it's a really good point to flag. Thank you. I wanted to talk a little bit more about
Right.
appetite and weight regulation, hormone network specifically, because I know we've just touched on your 20,000 plus survey and the insights you've seen, but can you talk to us about those hormone pathways and like what impacts appetite, fullness, cravings, energy, and why this change takes place?
Yeah, so we've got some survival biology going on here. We have a
Right.
hormone called ghrelin that makes you feel hungry. And this is what kind of when you feel your stomach growling, right? That's ghrelin.
Mm,
And there's actually a medical term for your stomach growling. It's called borborygmi. And it's just like one of these little factoids that I think is so
I
funny.
love it.
So ghrelin will go up when you're hungry, before meals, and it goes up when you restrict calories, and it goes up when you have weight loss. So this is the body defend. Remember, we evolved over millions of years, probably. We've only got fossil records back 100. It looks like humans have been on the earth, like Homo sapiens specifically, for 100,000 years. And so when we want to lose weight, we're fighting against evolutionary biology.
Mm.
And that's why it becomes so hard to lose weight, because we grew up in scarcity. And
Yes.
when your body gets to a certain point, it's like, oh, this is great. Let's stay here. And it doesn't agree
Mm.
with us that you want to look a certain way. So ghrelin works in your brain,
Right.
and the hypothalamus is a center in your brain. And when you eat, it gives you dopamine, which is,
Mm.
yay, a great reward
Mm.
hormone. Okay. And then leptin is the one that makes you feel full, right? It comes
Right.
from the fat tissue. And so more fat means more leptin. And this will signal that you're full and that you have enough energy. But in obesity, we have something called leptin resistance where your brain just doesn't respond to it. And so when you get to a certain point, this is why there's paradoxical hunger in people who are obese. They have excess energy, but they're always
Mm.
hungry because they have this leptin resistance. Their brain doesn't respond appropriately to leptin. And then there's also some genetic problems with leptin where
Mm.
there's obesity because they just don't have the right signaling pathway or the genetic pathway for leptin. So the gut satiety hormones, we've all heard of GLP-1 now,
Yeah.
and we release these in our blood system when we eat, and they slow gastric emptying, they reduce hunger, and we've known about these for 20, 25 years. We've been studying them. We just found out how to use them
Mm.
properly. They're relatively safe. Of course, there are some side effects, and we can talk about in a minute, but
Mm.
native GLP-1 that we make only lasts for 90 seconds or so. And what's really cool about the manufactured ones is that they last for 5, 6, 7 days.
Right.
Um, and
Right.
then we also have peptide YY, which suppresses appetite. We have cholecystokinin, which will promote fullness, also makes your gallbladder squeeze. And then we have insulinotropic peptide. That's what that GIP is.
Okay.
And that will enhance more insulin secretion. And so you put these all together, and these are all areas of active research, but we have some weight loss drugs. One is GLP-1. We have the GLP-1 GIP combination, and then we have some new ones that are coming out that are still in phase 2 and 3 trials. So they go through brain and vagus nerve. So it's
Mm.
upstream, downstream, and your brain will integrate the whole mechanical and chemical signal. That's
Yeah.
the decision if you're full. But depending on what you're eating, so processed food really does affect our brain because it's manufactured to keep us coming back.
They're very clever. Very, very clever. That's really interesting. I think really good to break down for our community. And I guess related to that, you touched on earlier what happens as we go through those life stages as a female in terms of our metabolic pathways. But why does weight regulation become particularly difficult for us in perimenopause and beyond? And what else is happening, I guess, as we age?
Well, let's move on. So we have estrogen that's modulating satiety signaling. Again,
Right.
satiety means fullness.
Hmm.
And estrogen works to make sure that CK and melanocortin pathways are working properly. But then again, this modulation shifts, right? And as that happens, then you may become less sensitive to ghrelin or more sensitive to ghrelin. So you get stronger hunger and more food
Right.
cravings. And then,
Right.
of course, like we talked about before, you get the more central fat, which is going to
Yeah.
disrupt the hormone balance. You have that active endocrine organ going on. which you didn't have in the past.
Mm,
And you start becoming resistant to leptin, so you're more hungry all the time. Why do I
mm,
crave food?
yeah.
And then carbohydrate cravings. And carbohydrate cravings are related to a couple of things. They're related to the ghrelin and the reward
Hmm.
pathways, but also in menopause, perimenopause, sleep becomes disrupted. And when
Right.
sleep becomes disrupted, when you are not sleeping properly, then the brain lives on glucose and that gives you
Right.
carb cravings. So that's why sleep is so important for overall health and for weight management.
So interesting. My goodness, it just feels so stacked. And I know that we touched on it earlier. I'd love to return to what I think you're going to cover in your next slide, which is this term set point, which I think for those of us that have started exploring weight loss and trying to navigate weight loss in midlife, it is a term that comes up. But I
Yeah.
would love you to just talk to me a little bit about what it is, like how it occurs in puberty, which you touched on at the beginning, that it's kind of set at that point.
But again, let's not forget that in menopause, right, as we age independently, we're going to not burn as many calories. Kind of,
Mm.
it's so frustrating. It's like it's all stacked against us. Um, but we have the mood changes as estrogen declines from our brain.
Yes. Yeah.
And then don't forget that women are the caretakers of humanity.
Mm,
And we have aging parents.
mm,
You know, some of us have children who never stop needing us.
mm,
I mean, there are true economic issues.
mm.
So all of that caretaking falls on women.
Yes.
So for the most part. So we've got this connection of biology and environment. So then moving on
Mm,
to set point, right? We have a
mm.
defended range. Now, set point is a theory. We don't
Right.
have hard evidence, but you know, relativity is a theory as well. So, and gravity was a theory before we proved it. So, but that's what really looks like that there's a range that we try to keep. So when you say to me, I've lost the same 10 pounds over and over, that's set point.
Yes.
You know,
Right.
when you say I've lost the same, I've got women who come into my DMs and say I've lost 500 pounds over my lifetime. And that's because we have a point that is defended, that's biologically defended, that your body doesn't want to get below. For me, I think that was right around 180 pounds. That's about as far as I could go, maybe 175
Mm.
until I started GLP-1. And then I was able to get myself back to my pre-pregnancy weight, which was amazing. 32 years.
And is
32
there any
years.
theory as to how it's I mean, you talked earlier about the theory being it's set at puberty, that sometimes factors like pregnancy can shift that set point. What determines that individual you see who will assert that they've never gained a pound, as opposed to the person that, like you say, spends about 30 years of their life going up and down and up and down, almost like fighting this set point that's been
Yeah,
established?
it has to do with hormones and the brain and how they
Right.
interact. We don't really know. We don't understand all of that biology yet and why it is that way. But, you know, when a woman who was metabolically healthy gets pregnant, has a baby, and then just can't lose the weight,
Mm.
she's labeled as someone who let herself go,
Yes.
right? And it doesn't help that we have beauty standards that are based on children's bodies.
Mm.
We have to address that. That
Mm.
the beauty standards are based on what children look like, hairless, no pouch, no, you know, never given birth to a child. But
Mm.
we as women can realize that the standards that are being foisted upon us are false.
Mm.
And I think that's very important.
You just touched on it a little bit in terms of, I guess, the myths, the societal pressure, this concept of what beauty is and what a desirable body shape is. And obviously all of that collides in midlife, not least because aging is not something we're supposed to do anyway. But related to that, what other weight loss or diet myths do you think we need to debunk in order to address weight gain and also managing that well and healthily, sort of mentally as well as physically?
So, yeah. Well, I think that the biggest myth we have is that weight gain is a motivation problem.
Mm,
So we have all these beliefs around weight gain that calories in, calories out proves it. It's just, and
yeah.
that calories are sneaking in. There's a lot of misogyny around it.
Mm,
And because we never really studied women. Whole belief, even from medical professionals, is, it's your fault.
Yes.
Well, you don't have control over your biology in that sense. What's
Yes.
changing at this time in our lives is physiology. It's physiology that changes, and no one's accounting for that. I don't see a lot of people talking about the fact that the physiology changes along with the menopause transition, along with pregnancy, along with puberty. All these things change. Another myth: menopause explains everything. I can
Yes.
move. So menopause, doesn't necessarily alone explain everything.
Yeah.
Menopause will shift fat distribution and insulin sensitivity, but obesity is regulated through appetite and energy defense systems. And if we ignore that, we're going to oversimplify the problem. And then again, we have this moral framing problem that, regain is treated like a character flaw when you have this defended range.
Yes. Yeah.
And you regain to a certain point, you regain +5 or 10. And then when you have cravings, it's treated as weakness. But when you drop weight, your hunger rises to get you back to that previous point. And your body will preferentially get you to stop moving. And it happens sneakily. It's like you just sit more. You just feel like exercising. So your brain is saying, hey, you've lost so much weight. I don't want you to move. I really want you to start sitting around a lot more. And this is the software of the brain working with the hardware of your body saying, you've lost enough weight. This is dangerous. When you know that, at least you have some information so you can try to override it.
Yes.
But even when you do override it, your body's going to say, eat more. And that's where GLP-1s come in to help. So what is happening is your biology is defending the fat mass. And then we have to talk about GLP-1s honestly, because they target real satiety and hunger. I have women who take a GLP-1 for the first time and say, oh my God, I never knew what food noise was.
Yeah.
There's so much quiet in my brain now.
Yes.
And it's the first time that all that appetite signaling just quiets down. And what we have to change in society, in ourselves, is that obesity is not a character flaw. It's a chronic relapsing regulated disease. And GLP-1s are one tool in long-term management.
That's so interesting, Dr. Gordon. Thank you.
I think it's important that we talk about how to get out of this cycle, right? So I move women from shame and blame into physiology. And then we look at the patterns over time. So it's hunger, it's sleep, it's body composition, it's what happens when you regain. And oftentimes when you can see the sequence, then all these assumptions fall away.
That's amazing.
If you go to my website, there's a training there called The Predictable Pattern Behind Midlife Weight Gain, and it explains all of that physiology.
That's amazing. We'll make sure that in the show notes, all of that is signposted, because I think that's the thing. Interestingly, the reason that we're hosting today is in part that obviously is a proportion of our community where a GLP-1 prescription would be available to them. But also, I haven't met a woman who doesn't have food noise, even if they don't, like you say, even if they don't know what it is. Because do you feel like, to your point earlier, so much is to do with our physiology, and it's so hard to address what is changing biochemically and try and maintain a healthy weight or weight you feel comfortable with. So even for people where GLP-1 may not be a prescription option for them, understanding how it works and understanding, to your point, the way that you work with people managing weight, because the GLP-1s is one tool in our toolkit, isn't it? But understanding better what's going on is absolutely key for all of us.
So let me bring up this slide. So how do GLP-1 medications work? So these are what's called incretin-based therapies, and incretins are gut hormones that get released after you eat. We talked about, we make them ourselves. And what do? They lower hunger. And when you lower hunger, then you're going to have better fullness, right?
Yeah.
So they lower hunger, they make the stomach empty slower, so you feel full a lot sooner. And it's also the reason why we have the side effects: nausea, reflux, bloating. But these medications started as treatment for diabetes type 2, which of course is a disease of inflammation. And it's a disease of obesity for a lot of people, not all people, but for a lot of people. And so it helps with management of sugar in the body. Now, one of the things I see as women come through the perimenopause transition is we see increased blood sugars, because estrogen is primarily responsible for that. Not only blood sugar, we see fluctuations in cholesterol. And when we can get women on some hormones in the perimenopause transition, we often see all of those things managed without a GLP-1. Some people still need GLP-1s, but it's interesting that this has been ignored. So what you'll see is women will go to the doctor, they're in perimenopause, their cholesterol's high, and they get a statin. Or they go to the
Yeah.
doctor, they say, I'm really moody, and they get an antidepressant,
Yeah.
which then has really bad sexual side effects. So we talk about GLP-1s. We've got 3 right now that are available on the market. We've got liraglutide, which I never like to prescribe because it's a daily injection and it's got really high side effects of nausea. But the weight loss is about the same as semaglutide. Semaglutide is a weekly injection. So this is the one that we know as Wegovy and Ozempic. I find that men tolerate this much better than women. Women tend to have a lot more nausea with it, but it works, and you can expect a 15 to 18% body mass reduction in 68 weeks, according to the studies. And then we have the dual GLP-1 GIP, which is tirzepatide. So this is Mounjaro, which is for
Yeah.
diabetes. And the studies went out to 72 weeks, and it was about 20 up to 25% body mass reduction. Now,
Right.
Eli Lilly has in phase 3 trials right now something called retatrutide,
Mm. Mm.
and that's GLP-1, GIP, and glucagon that looks like it's muscle sparing, which is really exciting.
And
Yeah.
what is the one that's the tablet? I know there's a lot of
So that's
sort of
Wegovy,
interest.
Wegovy tablet, that's semaglutide, only available from Novo Nordisk. It has a proprietary special covering which survives the stomach acid. The tablet form is available. It's come through the trials, it's available, but you have to use the brand name because the
Ah,
biggest issue is that this snack technology is only available from Novo Nordisk brand.
right.
So we've been
Mm.
compounding medications forever. Do I have
Mm.
any trouble with compounded semaglutide and tirzepatide? No, I don't. It's the same active ingredient as long as you're getting it from a reputable pharmacy. The issue is that when it comes to the pills, we have 2 problems with things we take orally. One, it has to survive the stomach acid. 2, it has to
Yeah.
survive first pass effect through the liver. If it can do that, then yes, we can get some meaningful weight loss. And I think we're 12 to 15% with the oral Wegovy pill, but you still have the side effects of
Mm.
nausea and bloating and reflux, and it's higher with that. But if
Mm.
you're needle averse,
Yeah.
it's something to try. Is it
Yeah.
affordable? I mean, they're trying. It's like $200 a month.
And I think, again, when I listened to our community in advance of this session and tried to get a sense of what worries them most, what they want answers on, I think that fear, that palpable fear that weight will pile on the minute you stop, is something that people really want to understand. And then the other point, which I'm sure you'll come on to, is can we change that internal set point, or are we always going to be managing the
Yeah.
same biological thermostat?
So I think before we move on to what happens when you stop, is we have to change the conversation around
Mm.
weight loss to it being, we take weight medication for a short time, we lose the weight, and we stop it because, we had a moral failing and we gained weight. Obesity is a chronic relapsing disease. And when you can change that thinking, it's very hard because we think it's a behavioral problem, right?
Mm.
And when I first started my TikTok, I was doing these text posts where I would say, obesity is a disease of inflammation and lipotoxicity. And I had to turn off comments. It's a calories in, calories out problem. It's a thermodynamics problem. And while many of those things are true, yes, overeating may cause obesity. Once you're obese, you have a disease, and that
Mm.
disease acts independently of your behavior. And so,
Yes.
that before we talk about, I'm going to take this, I'm going to lose weight, I'm going to stop it, we
Mm.
have to realize
Hmm.
that if you have diabetes, are we going to stop your medicine?
Yeah.
No. If you have high blood pressure, are you going to stop your medication? No. So you have obesity, we have medication to treat it. So what does happen when you stop? Well,
Mm.
you have an underlying regulatory system that will take you back to your set point.
Mm.
So what happens while you're on the medication, you've got a dampened biological drive to regain, your appetite signaling is going to slow down, and the ghrelin is not going to go up, right? So that's
Mm.
the hunger hormones. I always think of ghrelin as the hunger like goblin.
Yes, because it does sound like a gremlin.
Yeah. So when you stop it, then the dampening effect lifts, the appetite signaling resurges, and you get most of the weight will come back within a year. All of the weight will come back within 2. And the Surmount 4 study showed this, that once you stop the medication, you regain at least 2/3 of the weight rather quickly. Now, does this happen for 100% of people? No, but for most people, yeah, So is it a lifetime medication? Yes, because we don't know how to reset set point. That is something that happens. It's really complicated. We're talking about multiple organ systems. We're talking about the brain, we're talking about the gut, we're talking about the liver, the stomach, all of these things, and the whole endocrine system. So it's huge. Yeah. If you think about every time you've tried to lose weight and it came back on, was it a behavior shift or was it a biological shift? Was it biology driving behavior? So it
Yeah.
really is a chicken and egg problem.
And is it true? I know you've got on your slide here that it's true for all weight loss methods. So, you know, is it literally at any point that we are trying to push down a set point that has been established in our bodies, that the rebound is the same, regardless of protocol? So, if it was a GLP-1 medication or if it was a highly focused diet program that I put myself on for 3 months, is it the same statistically in terms of that rebound and the timeframes in which it happens?
Yeah, except for when you talk about diet and behavior alone, there's a 90% failure rate.
Wow.
So diets don't work, and
Yeah.
that's how Weight Watchers makes its money.
Yeah.
So
Yeah. So the weight loss meds work. It's just this point around what happens when you stop.
right. So we don't recommend stopping them.
And do you think, in terms of the kind of scientific discussion that's being had, because I think that is the nuance perhaps in the conversations that women are hearing or being privy to on, social media feeds and all these things where we end up having to get our information, is there is an assumption that you would stop. And obviously, again, going back to the hormone therapy piece, there are differing opinions within the medical community as to whether you would stop hormone therapy at any point, or again, whether that is just something you continue for the rest of your life. So do you think there's consensus within the medical community in terms of GLP-1s being a medication that you don't stop?
There is not. So I think that because we have this moral framing
Yes.
about obesity, then the whole thinking around it, when people reach a normal BMI, which is, BMI is the worst measure. It doesn't really tell us anything. It's just height over weight. Insurance companies want to stop. They want to stop because they want to keep their money. But, we pay insurance for health care, and obesity care is health care. But the finance studies show that it's cheaper to do an irreversible operation than it is to provide weight loss medication, even though the operations are 65 to 75% successful. And what I mean by a weight loss operation, like a sleeve or a Roux gastric bypass, will actually reset the set point. It's the only thing that we know that will actually reset the set point, but that's only for 65 to 75% of the people who have the operation. Most people will, then we have 25 to 35% that will regain their weight. And then they need a GLP-1 or they need a revision or something. It is the bariatric surgery data that leads us to say this is a chronic relapsing disease. When I went to Obesity Week 2 years ago, there was a woman who presented who she'd had a sleeve, then a duodenal switch, which are 3 different operations, and regained through all of them, and then went on a GLP-1 and actually was able to keep her weight off. And so we have to really look at disease management. Now, there are behaviors that go with that, right? So what is successful maintenance? Well, we have to keep the structure. So when you think about whenever you've lost weight in your 20s or your 30s, it was usually because you were doing some sort of exercise routine, and then you stopped it because life happened. So we have to keep on with the exercise. We've got to do weight training particularly, and muscle is a longevity organ. And so the one behavior that we can say that confers longevity is weightlifting. So we have to do resistance training, not for weight loss, but for health. Muscle mass stabilizes metabolic rate. And while we're on muscle, we should talk about muscle mass loss. The data that was presented at Obesity Week in 2025 showed that people on semaglutide lost 2 to 2.5 kilograms of muscle per 10 kilograms of weight lost. Average people on weight loss is 1 to 1.5 kilograms. So when somebody says 50 to 60% of the weight you lose is muscle, they're wrong. It's 100% more than if you did it with diet and exercise alone, but it's still not as much as we thought.
Right.
So
Right.
that is actually measurable. And for somebody who, is stuck and they start
Mm,
taking a weight loss medication, we have to be careful. And so I tell my patients, do a full body workout, 20 minutes twice a week, and that will help you maintain your muscle mass. If you
right.
want to gain muscle, you have to eat more.
Right.
And eating is scary to people who've lost weight.
Yeah.
And so not only is it a behavioral shift, it's an identity shift because you
Mm,
have to, most women and men who have been obese most of their lives look in the mirror and see somebody new, and they have to actually come into a new identity. And you
mm,
have to embody it, because if you look in the mirror and say, I don't recognize that person, I don't know who that is, that's where you get to spend time in front of the mirror saying, this is who I am, this is what I wanted,
mm.
and start to embody it. We also
Amazing.
have to keep up with behaviors of weighing yourself, watching trends, paying attention to whether you're moving or not. Regain will creep.
Yeah. Yeah.
And then you got to watch your eating patterns. You got to make sure you're getting enough protein. 1 to 1.5 grams of protein per kilogram of ideal body weight is what we're looking at as good. And then there's a
Mm,
lot of highly palatable, energy dense foods that we want to eat. And when you start to repair your relationship with food, you can find a way to have some of those things, but not always. So it's one of the things that can happen with weight regain is a drift towards more processed foods.
right.
So if you're somebody who gets a lot of dopamine from food, what happens when you take a GLP-1 is that dopamine rush from food goes away, and you have to
Yeah.
find other things to allow yourself to enjoy your life, which may or may not
Mm,
be coming from food.
mm.
And in the first, I would say 2 months or so when I started GLP-1, I just didn't care about much of anything. It was like, I
Mm.
called it the I don't give a shits.
Yeah, yeah. So it's like a low, is it like is it depressive almost? The joy goes a little bit.
Yeah, the medical term is anhedonia, and we see it in people with depression with
Mm,
lower dopamine signaling. But what I like to tell people, especially women in midlife, is if you're in a place where you have lost your spark or lost your joy,
mm,
it take some time and look at the things that really turned you on before you started living life. So when you were a
mm,
teenager, when you were a preteen, what did you like to do? What turned you
mm,
on? What did you like to read? Did you like to write? What did you like? And when you go back to looking at those things, you can find places where there's dopamine. But you
mm.
may have to like dig
Beautiful.
up old journals and figure
Yeah. Well,
out
again, back to
everything.
your story, I guess you started this conversation today talking about you rediscovered your love of gardening, sourdough, baking, making, all of the things that we've maybe forgotten. That's such a lovely thing to think about, how you bring that dopamine in through different signals outside of food.
Yeah, exactly. My favorite time of gardening is not harvesting, but taking care of things as they grow. Not when they're so big that they need a lot of maintenance, but when
Mm.
you're just getting started, just the joy of getting that garden going
Yeah, no, I think
and
it's beautiful.
watching the
Um,
seeds grow.
and I know we'll be sharing details of how people can get in contact for our US community members so they can really understand how you work with your clients because you do it in such a holistic, unique way. It's really interesting for people to dig into. But can you talk a little bit on almost a structure that we need to think about? But I know also you talked to me in preparing for this session around understanding what the
Mm.
patterns are. Can you just talk to us a little bit about that before we close?
Yeah, sure. So humans are a system of systems, and
Mm,
medicine has become very fragmented. So you
mm,
go see, over in the UK, you call it a surgery, right? It's where you go see
yeah,
the doctor.
yeah,
And I think that's really funny as a surgeon because we don't know what that means. So you'll go see the doctor, and the doctor will send you off to this specialist or that specialist.
yeah.
And there's nobody who is really commanding the orchestra,
Mm,
who is looking at the whole picture and saying, I think that this guy's right, but maybe this is not the right drug. And so maybe can we talk to them about how to do it this way or that way?
mm,
And so what I do when I see patients is we look at the whole picture, and then we start to look at pattern recognition over time. And that's why when somebody comes to work with me, it's a 1 year minimum. It's a
mm,
5-figure investment. It's a whole pattern recognition. And then we work together to achieve optimal health,
mm.
especially after you reach maintenance. But then we have education, and
Mm.
our first educational offering is something called the predictable pattern behind midlife weight gain, and you can get that at my
Brilliant.
website.
And how do people do that? They just go to the website to find that. Okay.
Yeah.
Great. I will make sure that they're in the show notes that we send out as well.
Yeah.
Thank you for that. And the final thing before I let you go, because you've been so generous with your time today, is I think that one of the frustrations I have as a researcher is this sort of assumption that science stands still, which obviously it doesn't. And there's so much more. We've talked about the sort of woeful lack of investment into female health, full stop. But can you talk to me a little bit about the gaps in knowledge? Because you two, I think, equally are outraged by where the funds go and the prioritization in terms of what's considered important in terms of unpicking and understanding health. Because I think, again, for females, we're very good at holding, you talked earlier about society holds us responsible for things that are outside of our control from a biochemical point of view, but we tend to adopt the same self-criticism. So many of us feel like it is all our fault. So talk
Yeah.
to me a little bit about why the gaps in knowledge are important to bear in mind.
Well, I think it's important to understand that at least in America, we've got a $47 billion health research budget.
Yeah.
And of that, women's health exclusively gets $5 billion.
Mm.
And while that may seem like a lot, research studies, designing and executing research studies, especially longitudinal research studies at the university level, is expensive
Mm.
and time consuming. And, it's frustrating that we have women make up 52.5% of the world's population. Okay. We birth 100% of the world's population.
Mm.
But we don't. I mean, I read somewhere that there was a study that was designed to examine estrogen on the heart,
Mm.
and they enrolled 1,800 men.
Mm.
So it's a gender bias.
Mm.
And the only way to combat this is to have really good controls in place that not only look at patriarchal bias that is just there, we have to look at integrated models of women across all stages. So we need some longitudinal studies, and these won't happen in our lifetime, but we can maybe start studying girls from adolescence through death to
Yes.
see. We need longitudinal studies to know what actually happens to women in their lifetime as they live. Those have to be more, meta-analyses. Probably you can't really randomly control women
For that
throughout their
period.
life.
Yeah. Yeah.
Throughout their
Yes.
lifetime, but can you enroll them and watch them? That's what they tried to do with the women's health study, women's health
Yes.
study or women's health initiative, but it was just so fatally flawed that a whole generation missed out on hormone replacement.
Yeah.
So
Yeah.
what happens in midlife? How do we keep our muscles and how do we expend our energy? So
It's really interesting. And I think, again, going back to the biochemical piece, when you think about that societal load, that caregiving load, the knock on influence of sleep deprivation, unpaid labor, inflammation through stress, that again, we don't really talk to, but that does then impact all of the things we discussed today, doesn't it? Cortisol, all of the things that you can see at the bottom of your slide, which again is fascinating. The relationship we have with food is so often built during those years when we're managing our emotions and the way that we respond to the world and the way that the world is placing responsibilities on us. I think that again is so rarely talked about.
well, there's a reason why the women choose the bear, right?
Mm.
And I don't know if it's the same in the UK as it is in the US,
Mm.
but in the US, I mean, women are attacked all the time for being
Mm.
attractive.
Mm.
Have to walk with their keys. And
Yep.
so I didn't mean to turn this into a feminist manifesto, but
I think it's a really important topic. So I think, again, back to your point, this weight gain, obesity, none of this exists in a vacuum. And I think, yeah, the gap is perfectly summed up on your final slide.
yeah. But right now, women are managing metabolic systems that we have under investigated,
Yeah.
and that's the gap. And so hopefully we're gonna bring some things to light.
Well, I love the fact that you're so rigorous and you have this opportunity with your community to actually be pulling out the insights, using the feedback you're getting, helping us understand better. Again, it is going to be the individuals, it's going to be the females that shift the balance, because that's how it's going to happen. So that's exciting as well.
I think that women have been at the forefront of change, and almost every time there's been major change.
Yeah. I think we're ready. We're ready. We're ready for change. Thank you so much, Dr. Gordon, for all of it. Honestly, it's been such a wide-ranging and phenomenal conversation with you. I will share show notes and details of where people can find you. As you know, a growing proportion of our audience at Mpowder are US community members, which is wonderful. So I'm sure they will be seeking you out. But for anyone, regardless of where you are tuning in and listening to this today, find Dr. Gordon on your social feed because she is that voice of balance that we've all been looking for. But thanks again for today.
Thanks for
Phenomenal.
having me. I appreciate it.